Thank you, Chairperson, and thanks to the Manoj and Purvi and Bansi Sabu for giving this opportunity at the last moment for me. I think after the osteoporosis and this diabetic combination drug, we are going to go to cardiology or lipidology, which is a very important thing and probably neglected in our Indian context. LPA, a small novel marker. I think we hear a lot of young deaths actually every day in the newspaper come, people below 40 getting myocardial infarction or something. But many times their LDL are not that bad. They have been controlled. In spite of that, we're getting this thing and we have not been screening people for the LPA small molecule is not commonly screened. So this is what we are every day saying. Of course, this is the data we have. Cardiovascular leading cause of the death, what else? 18 million compared to malignancy, respiratory disease or diabetes itself. So cardiovascular still remains, and especially in Southeast Asia, India, we have a much younger age group and with a high prevalence of diabetes actually. This was a man, a Norwegian man, who invented the lipoprotein A molecule. This is Kari Berg actually. This is actually ApoA and LPA, LDL-like molecule are covalently bound to the ApoA. This is LPA molecule circulating in this actually. It's genetically determined and the label should remain constant throughout the thing. LPA is a pro-atherogenic and pro-inflammatory both. Atherosclerosis is one part of it, like LDL does it, and also it is the inflammatory molecule actually. LP is a cholesterol-rich LDL molecule containing ApoA covalently bound to ApoB. In addition to pro-atherogenic property, it has a pro-inflammatory property, so some anti-inflammatory drugs might be helpful in managing the LPA. LPA levels are 90% genetically determined by variants of LPA gene, we're going to see, and gender, age, and environmental illness and diet have very few influence actually changes. Once you have a LPA particular level, it will not hardly change with the diet, environment factor, all that thing. It will remain for the lifelong same risk actually. Currently, the physiological role of LPA remains determined and potential role of LPA for the prothrombotic activity remains unproven. This is the molecule LPA which we are going to discuss along with the LDL. Already we all know and we have been hampering with statin, high dosage, ezetimibe, bempenetic acid, all we have got it actually. So these are the various isoforms of this single 1 to 40 there are, and some of them are very important like 4, 8, and 24 and 40. These are genetic markers for this LPA which are important actually. LPA is both most common monogenic CVD risk factor, one of the strongest genetic CVD risk factors, and actually the genetically determined. Elevated LPA is not rare, about 1 in 5, so 20% of the people will have high LPA level as a cause of cardiovascular death disease. Because 80% may be related to 81, but I think out of 5, 1% will definitely have LPA as a cause, which has never been routinely tested. Liver repeat profile doesn't include LPA, and it's been only done when the patient have a younger age group, a very strong family history, or something is actually, we first come to that. In comparison to familial hypercholesteremia, established monogenic CVD risk factor, has an estimated prevalence of 1 in 33 people, 25 million worldwide. And of course, India has very high incidence actually. We find actually Africa and Asia, Southeast Asia, compared to the Western countries which have around 15% to 20%, we are around 30 to 25%. And even the Australia and other countries have 10 to 20%. So we are quite higher. Estimated prevalence is between above 50 milligram will be taken as an incidence. The Interheart study, which was Sarem Resource actually study by the Indian origin Canadian man, who study showed that the median LPA concentration is highest in Africans and lowest in the Chinese. LPA levels are very across the ethnicity, which are partially explained by the genetic variations across. So you see the Latin America, the Africa, Middle East, Southeast Asia and Africa has the highest, and the Chinese and other people have lesser actually. So LPA gene responsible for elevated has been found to be strongest genetic cardiovascular risk factor. LPA gene is fully expressed at a very young age group actually. By the age of 2 years, LPA gene is fully expressed, and by adults, LPA levels are usually attained by the 5 years of age. So what at 5 years you do, maybe remain throughout the life. So maybe need much younger patient to be screened for this actually, very younger age group, and especially some strong family history or something. Genetic influences, I think these are SNP, single nucleotide polymorphism. 2 LPA SNP variants actually have been very strongly associated with increased LPA level. And LPA gene variants, several LPA gene variants have been now reported that decrease the LPA concentration. These variants include loss of function, mutation, and splice action. And KIV2 repeats, as the individual expressing the few KIV repeats, resulting in a small ApoA isoform, which an average markedly higher LPA concentration than individual carrying the large APO. So what therapeutically, how can we go? Elevated LPA and LDL levels are independent risk factors. So in contrast to secondary prevention, there is Copenhagen general study that showed the incidence rate of the MACE associated with the elevated LPA level was maintained despite varying levels. LDL was brought down below 55, 40 as per the newer guidelines In spite of the LPA is high, people will carry the cardiovascular disease such that LPA associated with CV risk independent of LDL. So LDL has nothing to do. We have been a lot of drugs now for LDL. Now, of course, statins, of course, we are hitting hard, especially the secondary prevention is going with the 40 mg rosuvastatin, 30 mg atorvastatin, ezetimibe, bempedoic acid, and PCKs. But I think for the LPA, we are only very limited drugs. So, 4 meta-analysis prospective population-based studies adults demonstrate the increased risk of MI at LPA concentration more than 30 and increase when it is 50, 70 or above. The LPA concentration above 30 do not show strong correlation, linear risk of actually either. The LPA levels primarily determine the LPA gene, which we have already seen actually. These are 4 genes which were actually 4, 8, 24 and 30. They were the most important actually marker. The atherosclerotic heart disease incidence linearly associated with LPA. You can see the findings of UK Biobank challenge. That's actually the LPA associated risk with the interim gray zone. It should also consider the other risk factor. So LPA level increases CV risk with as the level goes up from 50, 100, 150, 200. And they have seen families which have more than 300 and they have very strong history, the third generation now getting into angioplasty and all that thing. It increases 3 to 4-fold MI risk. Aortic wall stenosis, AS, now which is typically the TIV actually lot of younger people, bicuspid wall, another thing is actually the aortic wall disease. Ischemic stroke again, the neurological problem also 1.6%. Heart failure is increased by 1.5 to 2%. CV mortality overall is 1.5 higher by LPA and all-cause mortality is also increased. So especially the MI, aortic wall stenosis, ischemic stroke and heart failure all are increased with LPA. The has shown this thing actually. The 20% risk reduction in MACE could be achieved with LPA, lowering 50 milligram over 5 years. The risk can be reduced by the LPA reduction by whatever methods we have certain drugs which will go. Particle concentration, the mass concentration is the same number of particles, but the mass concentration is a different actually shown. The major influencers genetically predominantly control LPA concentration, 70 to 90%. Lesser influencers, chronic kidney disease, LPA will slightly go up, GFR will go. Liver diseases, LPA will slightly go. Hypothyroid again, like lipids go up, LPA slightly go. Menopause also slightly LPA go. And any inflammatory process acute reactant, the transient LPA will go up. Any inflammatory process actually when necessary. And limited lifestyle changes, diet, physical exercise, limited or no impact on LPA plasma concentration. You will find hardly any change by lifestyle modification or the exercise or the diet. LPA remains the same, but I think these are some of the factors. And LPA and the CV risk, as you see, the non-fatal MI and coronary death is increasing, ischemic stroke is increasing, and of course non-vascular death also. The genetically predicted LPA coronary heart disease risk is actually genetically predicted. LPA concentration that goes on increasing actually. The increase in absolute risk caused by the increasing LPA category. The atherosclerotic cardiovascular risk increases. The aortic stenosis, which is also now we have an aging population, geriatric population much, and a lot of people after 65, 70 do cut aortic stenosis. And of course, the surgical part has now been replaced by the transcatheter wall replacement. But there is a large population who is coming with a high gradients actually. The LPA will be other cause of that. Reduction needed to mitigate the increased CV risk caused by the LPA depending, because we don't have anything. We do want to reduce the at least LDL to some extent, and then what we can do for LPA. The chronic kidney disease is one of the most common diseases worldwide. In addition to impaired kidney function, patients with chronic kidney disease have increased risk of atherosclerotic cardiovascular disease. And to a lipoprotein conscious statement that European Association made, impaired kidney function may increase the levels of many studies document the patient, the impaired kidney function and chronic kidney disease have a high plasma lipoprotein. And so then actually they have also a high levels of the coronary artery disease along with the kidney disease. Association of the lipoprotein with severe degenerative aortic wall disease. This was actually one of the trials shows that aortic stenosis is increased with high levels of LPA. So in fact, LPA level more than 100 significantly associated with the risk of the severe degenerative AS, subsequent aortic wall regurgitation, regardless of basis severity AS. Such associations were not observed in other etiologies of the severe AS. Of course, the aging and all this thing. This was published by the American College of Cardiac Physicians actually. So aortic stenosis, it will again lead to atrial fibrillation, atymplant or potential cause for mediator of that. As the aging population goes on, we are getting lot of people of atrial fibrillation and the risk of stroke and anticoagulation again. After I think 75, almost 5% of the population will have atrial. The LPA is one of the causes for the high incidence of atrial fibrillation. The drugs which are available to us, nicotinic acid is a very cheap drug available to us, which actually we are very fond of it actually, but it went out of the market because of 2 trials we're getting. Mipomazan is one drug which reduces it 20%. Lometamide is another which has 17%. Statin doesn't decrease LPA, in fact, contrary, increase it. Ezetimibe fibrillate bile separation neutral. PCKS inhibitors only have 20 to 30% and lipid apheresis is actually 70%. So mainly the stage now PCKS inhibitors are the only drugs which have. The PCKS inhibitor effect of LPA is quite significant The median change was LPA, the Evolocom was almost 26% toxicity, and individualized variability of the response was seen in the Fourier trial, which is the Evolocom was APC-Cas inhibitor. Predictive magnitude of the LPA lowering, variety of genetic estimates ranging from 66 actually, they have shown that there is a lowering, of course, the help to reduce the risk actually. Palicrisan is a new drug which is going to come in the market, still not available to us. It's a very potent drug, and 286 patients, a small trial which actually was used and is shown to be a very good drug, will be available to Sun. It affects the palicrisan hepatocyte directed second generation ASO design target, bind ApoA, and this is actually demolished. It lower the more than 50% the additional pharmacodynamic effect and ideal safety profile initial. The prolonged pharmacodynamic effect allows monthly dosing and prolonging the actually benefits in patients. So once a month injection actually. So mechanism of palicrisan, this is a review. Actually, it works at the liver level, LPA and mRNA, RNA blocking actually, and preventing APO production, leading to decrease in the LPA particles. So what is drug? Horizon study was actually antinuclear administered monthly injection, 7,000 patients, and the study was positive, has shown a very good result in the LPA reduction, and of course reducing the cardiovascular mortality, in fact, actually compared to the placebo subcutaneous injections. Olpasiran is the other mechanism, which actually is again small interfering RNA directed to the liver. The antisense actually RNA induced silencing complex. This binds to the ApoA, leading to its degradation, preventing markers. So the olpasiran actually was 10 milligrams, 75, 225, 225, and placebo was compared, and 75 was proved to be quite useful without a high dose in the trial, Ocean trial, a dose trial to study. The changes actually was shown, the olpasiran was 75 milligram was found to be quite sufficient compared to the 10 milligram, and higher doses of 225 were not required actually. So achieved LPA by baseline LPA, higher doses achieved nearly complete suppression LPA regardless of baseline concentration. This other girl, olpasiran was compared with Ocean A outcome studies, actually 6,000 patients, and data is still actually coming this year and going to be under. So palicrisan, olpasiran, SLN phase results actually has shown a very good. So I think couple of days current ES recommendation, low risk actually the green part actually, then yellow part is the moderate risk, and the red part is the high risk. So high risk patients should be, of course, to be tried actually. Just 1 minute. A Canadian Cardiovascular Society guidelines management dyslipidemia and prevention of cardiovascular disease recommends lipoprotein A measurement for everyone once at least in lifetime. Our LPSA standard is still work in progress. We do not have a data of treating patients in lifetime, and less than 5% of the elevated LPA with a statin is a cost effect. So summarizing, the remarked evidence as a base support the casual role of LPA and CHDs, remains unknown how large or absolute reduction may be required to see the meaningful, at least 50% reduction, or to bring it down below 50, which is right now actually. We want to wait and lower LP lowering therapeutics, the newer drug, olpasiran, palicrisan, all these things are coming up. Traditional therapy mitigation recommended high risk individuals with elevated LPA concentration. The tremendous promise and enthusiasm regarding the LPA lowering therapeutics are in development. Of course, all these are research molecules, are going to be quite expensive. And this is the LPA, both most common monogenic CV risk factor in one of the strongest genetic CV risk factor. LPA gene expression remains genetically stable throughout the life. 3 genetic influences contribute to LPA level: SNP, LPA gene variants, and KVI. as a genetic. The genetic influence is predominantly elevated LPA levels associated with the risk of MI, ischemic stroke, peripheral artery disease, valvular disease like aortic stenosis, among others, and genetic lowering LPA associated with the reduce all these risk of death. And pelagrasone targets the LPA gene at mRNA level and prevents upward production, leading to decrease in the LPA particle assembly. This is the one a polling question now, which is the following statements are true or correct. LPA concept primarily genetically determined. Individuals with high number of single repeats have concentrated statins are effective in reduction. So I think the answer is 1 and 2 is correct. All are not correct actually. So LPA is a small molecule neglected actually. So quite common in Southeast Asia, especially India, with a very high cardiovascular mortality. At least measurement should be done. And whatever measures, I think drugs are limited today, but I think PCK is the only thing. I think for the future, there are a couple of drugs are coming up, and hopefully they will be soon available to us at a cheaper rate. At least inflammation part we can target with a simple molecule like colchicine, which can be used and actually can reduce the inflammation. There is a lot of data of colchicine with inflammation and can reduce the mortality. Thank you very much.